Excellent. Well, thanks, Martin, and thanks everybody else from the team for having me in Vancouver for the year. I really appreciate it and have had a good time. I understand that the weather, everybody's been telling me about the upcoming rainy season for Vancouver, and I've yet to see it. So just to up the mood, I've put a photo of Wellington up on a sunny day, which only happens approximately 3 times a year. So that's Wellington, where I'm from and where I'll be going back to.
Good.
So the objectives of my talk on oligo-metastatic prostate cancer, first I'd like to outline the definition and then review the management. And in terms of reviewing the management, we'll first cover the primary disease, followed by the metastasis. And regarding the metastasis, we'll talk about metastasis-directed therapy, followed by systemic therapy. And then I've also gathered some local data from here in Vancouver, which we'll review. So just to put some context, and I'd like to introduce a case. He's a 65-year-old gentleman named Mr. JT. He had initial PSA of 7.2 and went on to have a radical prostatectomy. The pathology revealed ISIP3 disease with negative margins in 2018. He had a post-radical prostatectomy PSA of 0.2. He had excellent erectile function due to the high-quality surgery he received here. And fortunately for him, he's just got a new partner who's young and fit. Unfortunately for him, however, his PSA has gone up to 1 in 2020. He had negative conventional imaging. However, he's gone on to have a PSMA scan, which shows some isolated right pelvic nodes. So I guess the question for the group is, what would you do? There's various options which I've listed here. You could start him on intermittent androgen deprivation therapy and consider an androgen receptor agent. He could proceed to salvage lymph node dissection. He could consider radiotherapy. Alternatively, he could have surveillance or continuous ADT. I guess there's a lot of factors to consider here, especially the fact he's got a new partner and his erectile function is important to him. So by way of introduction, 5 to 20% of prostate cancer is metastatic at presentation. Just talking about how metastases happen, there's a few theories, but some of which I'll talk about here. Historically, there's the contiguous theory described by Halsted, where metastases spread by an anatomical sort of pattern by lymphatic and vascular drainage. An alternative theory proposed is the systemic therapy, where it's sort of a binary theory where the cancer is either localized disease or systemic disease. So even if they identify several nodes or several isolated metastases, this theory would suggest the patient indeed has polymetastatic microscopic disease. However, an alternative theory is described by Weisselbaum and Hellman, where there is oligometastatic disease, and the disease is somewhere intermediary between localized disease and polymetastatic disease, where there may be several lesions which may be amenable to localized treatment. And that's what we'll be focusing on today. In terms of definitions, there's a variety of different definitions for oligometastatic disease. Generally, the accepted consensus number is less than 5 metastatic sites. But as you can see here in this meta-analysis, the studies describing or looking at oligometastatic disease use a variety of different scans and a variety of different numbers, ranging from less than 1 or less metastases all the way up to 5 or less metastases. But as a general, in guidelines, it's described as 5 or less metastases. As well as the number of metastases, there's different presentations for oligometastatic disease. It may be de novo oligometastatic disease, where the primary hasn't been treated. Alternatively, if the patient's had their primary treated, the patient would be described as having recurrent oligometastatic disease. In the context of patients having had previous systemic therapy, i.e. castrate-resistant disease, the patient would have progressive oligometastatic disease. In today's talk, I'll be focusing on the first two. So reviewing the natural history of oligometastatic prostate cancer, fortunately it has a favorable prognosis. As you can see here in these papers, firstly by Singh et al. In a number of 74 patients with 10-year follow-up, they had a 5-year survival rate of 73% for those patients who had 5 or less metastases, compared to 45% in those patients who had greater than 5 metastases, with a significant p-value. Supporting this evidence with Sridharan et al. In a off-group of the RADAR study, you can see here in the graph once again, the volume of metastases would suggest worse outcomes in terms of survival. So the way I try and think of prostate cancer is on a continuum. And this is a graph I've sort of generated, where on the left is localized disease and on the right is polymetastatic disease. And somewhere in the middle lies oligo-metastatic disease. And so different patients would lie at different areas on this continuum. And depending on where they lie, you'd have different focuses on your therapy. If they've got localized disease, clearly you'd want to have local treatment, whereas if they've got polymetastatic disease, you'd want to have a focus on systemic therapy. However, the patients we're going to talk about today lie somewhere in the middle, and we need to try and tailor our treatment goals for those particular patients depending on where they lie on this continuum. Now, I guess the key is to identify where particular patients lie on that graph. And in order to identify where they lie on the graph and therefore guide us with our personalized treatment options for those patients, we have molecular methods where we can look at microRNA, genomics, and circulating tumor DNA. We can have conventional imaging such as CT, bone scan, and MRI. Most importantly, we have PSMA scan at this stage. So the most pertinent paper I could find relating to specifically to oligometastatic disease was this paper out of Chicago by Lucia et al., looking at microRNA expression in oligometastatic disease. So they analyzed tissue of the primary biopsy specimen as well as from metastatic sites in 34 patients who had 1 to 5 metastatic site and therefore were defined by our consensus definition as oligometastatic disease. They applied radiotherapy to all of these metastatic sites and did 3 monthly imaging. The patients were then divided into oligo versus polymetastatic disease 4 months after they've completed their radiation based on conventional imaging. And they defined it by 5. So polymetastatic was defined as if they could develop more than 5 metastases. They extracted RNA from the tissue, and they compared microRNA signatures between those who maintain oligo disease compared to polymetastatic disease. They found that tumor samples showed clustering different between the two groups. So they would suggest that microRNA can be used in order to identify those patients who have oligo disease versus poly disease. I should say that microRNA is a non-coding RNA. That's what microRNA is. In addition to using tissue, we could use the blood. So this is called plasma liquid biopsies. So circulating tumor DNA can help profile metastatic prostate cancer and help with prognostication. This is actually a local study by Van der Hove et al. Done here with the Vancouver team. They sequenced circulating tumor DNA from plasma, and they also got DNA from prostate tissue in 53 patients with de novo metastatic castrate-sensitive prostate cancer. So this isn't specifically looking at oligometastatic disease, but looking at castrate-sensitive disease. And they found that these plasma samples can complement the tissue biopsy genomics. Furthermore, in a study by de novo et al., they actually took circulating tumor DNA pre-chemotherapy in those patients who had castrate-resistant prostate cancer, and they stratified their patients into those who had less than 5 circulating tumor DNA per 7.5 mL and those greater than 5. And they found that this is a significant prognostic indicator for the patient's survival, as you can see in this graph. So in summary, circulating tumor DNA, while not looked at specifically in these papers for oligometastatic disease, can help us as a prognostic marker for the future. Looking at tissue biopsies, once again, Van der Kove et al. From the Vancouver group looked at gene alterations on tissue biopsy and localized disease, and compared to it in other papers looking at de novo metastatic disease as well as castrate-resistant disease. And there are some of the gene alterations here in the graph, as you can see in the horizontal x-axis, and you can see there's clearly different patterns of these gene alterations in different stages of disease, i.e. different points on that continuum, from localized disease to de novo metastatic castrate-sensitive disease, all the way through to the castrate-resistant disease. So we can use we can potentially use these genomics in order to aid us with prognostication and risk stratification. Putting all of those moleculars in terms of the relevance for us as urologists, however, the most common tool we use is imaging at this stage. And imaging can provide us with a snapshot in time as to that patient's metastatic burden. And the most sensitive imaging we have to us at this stage is the PSMA scan. Now, just to review what PSMA is a transmembrane protein expressed on apical regions of the splastic cells. It's expressed in 100 to 1,000 times higher in those patients with in prostate cancer cells, and it has higher expression in those with higher grade and higher stage disease. It's important to know that PSMA is actually only expressed in 80 to 90% of prostate cancer, so there are still prostate cancers where PSMA is not going to be positive. Most common indications used at this stage are for primary staging and high-risk disease, as well as restaging post-primary treatment. However, there could be a significant role for PSMA for the identification of oligometastatic disease. Now, looking at the PSMA positivity versus PSA, this is a meta-analysis by Pereira et al. In European Urology. It's an Australian meta-analysis looking at 15 studies with 1,300 patients where they correlated PSMA findings to histopathological findings. And as you can see here, with a rising PSA in the setting of biochemical recurrence, the higher the PSA is, the higher the positivity is. So we as clinicians have to balance when we perform this PSA in order to achieve an outcome. There's no point in doing it when the PSA is too low and the yield would be too low, so it would be a wasted resource. So I understand here that the cutoff is approximately 0.5. The doubling time can also be, from the same paper, the doubling time also affects positivity. So you can see that a short doubling time of less than 6 months has a much higher positivity compared to patients who have a long doubling time. So PSA dynamics, as well as the absolute PSA number, would guide us as to the yield that would be achieved by performing a PSMA scan. So with PSMA scans has actually caused a stage migration where disease that's identified on, when you can compare disease identified on conventional imaging to PSMA imaging, we can get a significantly different picture. As you can see in the diagram below, the bone scan would suggest there's fairly indolent disease with few metastases. However, in this same patient, when you're performing a PSMA scan, you could potentially identify widespread polymetastatic disease. And this is reinforced by a study by Fendler et al., who reviewed 200 patients with the so-called M0 castrate-resistant prostate cancer on conventional imaging. And they found that out of the 200 patients, 196 had positive PSMA scan and had metastatic disease. So that study in itself would call into question the so-called M0 castrate-resistant prostate cancer. So what I'd like to summarize from these slides thus far is that we can use bloods, we can use genomics, and we can use imaging in order to risk stratify and prognosticate patients and we need to develop a tailored, specific therapeutic plan for patients based on these tools. And lots of them are still in their infancy, but these are things we need to work on in terms of identifying patients suitable for treatment. Now we're going to talk about the management of the primary. So looking at the primary and de novo metastatic disease, there's two rationale for treating the primary. Firstly, the first priority would be a cytoreductive, and considering an improvement in survival. It can reduce tumor proliferative factors, it can reduce tumor immunosuppressive cytokines, and it can reduce tumor burden, and they may potentially improve survival. It can also primary treatment can also have a goal of avoiding or managing local complications. So those are the two main goals of treating the primary in the setting of oligometastatic disease. So from the EAU guidelines this year, it suggests we should offer radical prostatectomy in highly selected patients with those with N1 disease as part of multimodal therapy. Now, importantly, there's actually no randomized data to support radical prostatectomy in the context of metastatic disease. This was one paper I found that had large numbers, but it was by no means flawless. This was done by Kolb et al. And published in European Urology, where they had 8,000 patients using the SEER database. 7,800 of them had no treatment. 245 had radical prostatectomy, and 129 patients had radiotherapy as their primary treatment. They found a statistically significant improvement in their survival of those patients who had primary treatment, as you can see in that survival curve, with survival 5 years overall survivals of 67% for those who had radical prostatectomy, 53% of those who had radiotherapy, compared to only 23% who had no treatment. However, as you'd expect, there were significant biases and confounders, and the study was retrospective. There was much higher metastatic burden in those who had no primary treatment. The patients who had no primary treatment were older. They had higher grade and higher stage disease. So irrespective of primary treatment, you'd expect those patients to have a poorer survival anyway. So I don't think this study necessarily contributes to our knowledge about the role of radical prostatectomy in the setting of metastatic disease. However, looking at local regional symptoms, this was a French study by Patrick Dow et al. In Uro-Oncology in 2015, where they had 263 patients with metastatic disease. They identified that 64% of patients presented with local symptoms. 46 patients required intervention for these local regional symptoms. This may be in the form of radiotherapy, or might be TURP or suprapubic catheter insertion, nephrostomies for obstruction or stents. 48% required admission for these symptoms, and this is despite 98% of them already being on ADT. So in summary, despite systemic treatment with ADT, although there's other options now, these patients were still suffering from local problems. And the table there below summarizes some of those symptoms, such as hematuria, dysuria, and so forth. There are further trials to evaluate the role of radical prostatectomy in metastatic disease. The most prominent one, the most relevant for oligometastatic disease, will be the Trombone study, which is out of the UK, and they've got a randomized trial comparing radical prostatectomy and lymph node dissection with systemic therapy versus systemic therapy alone, and they're using docetaxel in addition to ADT. They are focusing on oligometastatic disease with less than 3 bony metastases in patients under the age of 75 who are fit and well. Thus far, they've acquired 51 patients All of them have been done robotically. They've got a 43% positive margin rate, which you'd expect as the high-grade disease. They've had one rectal injury. Further results are pending. A study out of Germany is upcoming called the GRAMP study, where they plan to enroll 452 patients, comparing the primary outcome in prostate cancer survival between those who have surgery and systemic therapy versus systemic therapy alone. And finally, there's the US SWOG study 1802, randomizing 1,200 patients to having local and systemic therapy versus systemic therapy alone. So hopefully these trials will actually provide us with some good data as to the role of radical prostatectomy in oligometastatic disease. In contrast to surgery, we actually do have reasonably good evidence for the role of radiation as the treatment for primary and oligometastatic prostate cancer. And I'm sure most of you are familiar with the STAMPEDE study, the STAMPEDE study looking at radiotherapy. So this study was a randomized trial of the phase 3 study out of the UK and Switzerland, looking at standard of care, which is androgen deprivation therapy plus or minus docetaxel versus standard of care and radiotherapy. Their primary outcome was overall survival, and in 2,061 patients, they had 40% were in the low metastatic burden. Now, in terms of the definition for low metastatic burden, they used the same definition as the charted study. So high volume was defined as 4 or more metastases with one outside of the extraaxial skeleton or visceral disease. So this study, although not strictly correlating to oligometastatic disease by our definition, is the best correlate we have. And they found a statistically significant improvement in both overall survival and progression-free survival following treatment to the radiation, following treatment to the primary with radiation in the setting of low metastatic burden. Now, moving on from the treatment of the primary disease, now we're going to talk about the management of the metastasis. So metastases were historically managed with systemic therapy, and that was usually ADT, whether that was going to be intermittent or continuous therapy. However, if we're going to focus on the oligometastatic patients, the question really becomes, can we cure these patients or improve their survival, or potentially delay morbidity of these systemic therapies by treating oligometastatic sites? So once again, reviewing the EAU guidelines, their paragraph on metastatic-directed therapy would suggest that there is no data to suggest an improvement in overall survival, and a systematic review has suggested that that metastatic-directed therapy is at this stage experimental. So broadly speaking, the approaches to metastases would be divided into radiation with stereotactic radiotherapy, salvage lymph node dissection, so surgical option, or alternatively systemic therapy. So the first study that I found, randomized study I found looking at stereotactic radiotherapy at metastatic disease, was the SABRE, was the phase 2 COMET trial. And this was done out of 10 hospitals from Canada, Australia, Netherlands, and Scotland, where they compared standard of care palliative systemic therapy versus SABRE. They had patients with 1 to 5 metastases post-primary treatment who were fit and well. They randomized 99 patients in a 2-to-1 ratio. Now, this study wasn't specifically looking at prostate cancer. It was all comers primaries, but 16 of the 99 patients had primary prostate cancer, and their standard of care systemic therapy was ADT. They had a median follow-up of 26 months, and treatment was usually well tolerated, except for those who had stereotactic radiation to the lungs, who there were 3 deaths from this, mostly relating to pneumocystitis. This study suggested a trend towards improvement in overall survival with a p-value of 0.09 in those who had SABR compared to the control, and they found a statistically significant improvement in progression-free survival in those who had metastatic-directed therapy. So this set a setting for metastatic-directed therapy for further trials. And the first trial I identified relevant to prostate cancer specifically was the STOMP trial, published. This is out of Belgium, led by Piet Oost, who's a radiation oncologist, published in the Journal of Clinical Oncology initially a couple of years ago. So the primary endpoint for STOMP was the use of ADT. There were 62 patients, and the inclusion criteria were up to 3 extracranial metastases on choline PET. They randomized patients into surveillance versus metastatic-directed therapy. In this study, you could either have surgery or radiation. They performed 3 monthly PSAs with choline on progression or on symptoms. And as I said, the primary endpoint was ADT use. They had a median follow-up of 3 years, and in terms of their numbers, they had 25 patients in the SABR group, 6 patients in the salvage lymph node dissection group, and 31 patients in the surveillance group. So in terms of their results, the median time to ADT was 13 months in the surveillance group versus 21 months in the metastatic-directed therapy group, with a p-value of 0.11. So you can see there's a trend towards delaying ADT with the use of metastatic-directed therapy. Importantly, there was no symptomatic or local progression in the MDT group. However, there was 3 symptomatic cases in the surveillance group and 6 cases of local progression in the surveillance group. You can see in the table below outlines the reasons or in the indications for starting ADT, which were mostly patients developing polymetastatic disease. However, as I said, there's cases of local progression and symptomatic progression in the surveillance group as well. The STOMP trial suggested a good PSA response for those who had MDT. So 75% of patients who had metastatic-directed therapy had a PSA response compared to the surveillance group, and that's shown in the graph here. The treatment was very well tolerated. Only 17% had minor grade 1 toxicity post-SABR. There was, in the operative group, there was 1 post-op genitofemoral nerve hypoesthesia and 1 patient with lymphedema. Actually, this year in the ASCO in February, there was a 5-year update to the STOMP trial where they found that the 5-year ADT-free survival was 8% in the surveillance group compared to 34% in the MDT group, with a p-value of 0.06. So this would lend further evidence to suggest that MDT may be useful in delaying ADT. Interestingly, they also found that metastatic-directed therapy may delay the onset of castrate-resistant prostate cancer as well, although this finding was not statistically significant and the study wasn't aimed at looking at this as an outcome. Moving on from the STOMP trial, a more recent study done in the last year was the Oriole study published. This is an American study, which is a phase 2 randomized trial comparing observation versus stereotactic ablative radiotherapy. So the Oriole trial was a randomized trial, once again comparing observation versus stereotactic ablative therapy. They had 54 men with 1 to 3 metastases on conventional imaging. All of these patients had previous definitive treatment of their primary, so all of these patients are recurrent oligometastatic disease. They've had no ADT within 6 months of enrollment, and they randomized patients in a 2-to-1 ratio of SABR versus observation. Now, one of the key things with this study is that those patients randomized to the SABR group got a PSMA scan. The investigators were blinded to the results of this PSMA scan. Those patients who were randomized to the observation group did not receive a PSMA scan. Their primary outcome was disease progression, and that was reflected in the use of ADT, progressive metastases on imaging, progressive symptoms, or increasing PSA at 6 months. So reviewing the results, they found that the progression at 6 months was significantly more in the observation group at 61% versus 19% in the MDT group, with a p-value of 0.05, and the progression-free survival was 5.8 months in the observation versus not reached in the MDT group. So metastatic directed therapy may have a role in delaying progression. An important point here is that those patients who had SABR and had untreated lesions on the PSMA scan had a significantly higher progression compared to those patients who had no untreated lesions. So just to say that again, the investigators were blinded to the results of the PSMA scan, so they might not have been aware of lesions not seen on the conventional imaging, so they may have missed some lesions. And those patients who didn't have all of their lesions treated had a poorer outcome compared to those who have had all their metastases treated. So if patients are going to go down the metastatic directed therapy treatment pathway, they should all have PSMA scans, and we should aim to treat all of their lesions. The Oriole study also did liquid biopsies, where they collected mononuclear cells at baseline and 90 days and sequenced the T-cell receptor. They found more differential clonal abundance in the SABR group compared to the observation group, with more contracted clones at 90 days. This suggests that SABR has a systemic effect on clonal populations as well. They found that greater clonality was associated with more progression. In contrast to the last studies I described, there's no difference in circulating tumor DNA between those who progressed and those that did not in both the observation and the SABR group. So in this study, they found that genomics showed a significantly higher benefit in SABR to those in high-risk gene-negative patients compared to those with high-risk gene-negative mutations. So genomics may have a significant role in SABR in order to identify who would benefit from it compared to those who wouldn't benefit from it. Now, we've talked about studies that have had ADT and progression as their endpoints. This is a German study by Struber et al. Who looked at survival as their endpoint for metastatic directed therapy. This was published last year in European Urology. So they did a matched case analysis comparing standard of care with immediate or delayed ADT in 1,800 patients versus 263 patients in the metastatic directed therapy. They looked at PSA, and they did that at PSA progression on PET scan. They had a median follow-up of 70 months, and they found that metastatic directed therapy had a significant improvement in cancer-specific survival at 99% versus 96% at 5 years, with a p-value of 0.029. You can note clearly that the survival rate is fairly high in both groups, even in the surveillance group. So the natural history of oligometastatic disease means we need to look at it over a long period of time in order to see any potential significant differences. There were issues with this study. It was retrospective. There was no standardization to systemic therapy. the use of ADT was based on the discretion of the individual clinicians. It was an unmatched population. The MDT group were younger, they had lower grade, lower stage disease, follow-up was limited, and only the MDT group had PET CT scans. So those with more than 5 METs, those on the ADT group didn't have a PET scan and may have actually had many more metastases, which we didn't actually identify on their conventional imaging. Moving on to which patients should have metastatic directed therapy. This is a study by Prostate et al. Out of Italy. So their aim was to identify patient selection. They looked at 654 patients with nodal recurrence on choline or PSMA scan. They found that their primary outcome was clinical progression, which they defined as skeletal or visceral metastases on PET with rising PSA at 12 months. They found a 25% clinical recurrence rate within a year, and that's a significant factor because early clinical recurrence was associated with increased mortality at 3 years. They had a median follow-up of 30 months. So the outcome of the take-home message of this study was that their risk factors for this early recurrence was a high Gleason score, a high PSA, retroperitoneal nodes, more than 2 metastases, and paradoxically, they would suggest that no ADT at salvage lymph node dissection was a risk factor for recurrence. So we're doing salvage lymph node dissections to avoid ADT. However, not using ADT at the time may result in higher rates of recurrence. Here are the survival curves for Prostate. So at the 3-year mark, approximately 50% of patients have had clinical recurrence. The 80% or 70 to 80% have had biochemical recurrence at 3 years, and 70 to 80% of patients are back on hormonal therapy. This is another study by Bravi et al. Now focusing on long-term outcomes. Most of these studies I've described so far have had short-term follow-ups. So Bravi out of Italy has looked at more long-term data out of European Urology. So they looked at patients who had salvage lymph node dissection for biochemical nodal recurrence on PSMA with a median follow-up of 8 years. So this is by far the longest follow-up we have in terms of data. They had 189 patients in 11 centres, and they looked at the PSA 1 month post-operatively as well as 3 to 6 monthly and imaging if the patient had a PSA rise. 45 patients died from prostate cancer, and on multivariate analysis, a good PSA response and receiving ADT were associated with lower prostate cancer death. So once again, this study is consistent with the last study suggesting that patients having metastatic directed therapy should have ADT at the time as well. So here are their long-term survival curves. Overall survival is approximately 60% at the 10 to 12 year mark. Clinical recurrence, approximately 70 to 80% have had recurrence. Only 10 or less percent have a biochemical recurrence free at 10 to 12 years. So most patients at 10 to 12 years have had recurrence. And similarly, ADT, only 5 to 10% are ADT free. So this study would suggest when looking at the long term, the outcomes in terms of ADT and biochemical recurrence aren't that good. When weighing up whether to give patients the metastatic directed therapy, we need to weigh up the benefits with potential complications. So this is a systematic review looking at both SABR and salvage lymph node dissection, 15 studies, and it suggests that the SABR group has actually very well tolerated with low significant complications. Similarly, with salvage lymph node dissection, there were no significant injuries no significant complications such as rectal injuries. Most of the complications related to lymph leak and wound issues, which were manageable. Now, Having reviewed all of the literature, I performed a review of the local data here in Vancouver. We had 25 patients who had salvage lymph node dissection between 2016 and 2020. 23 of these patients had initial radical prostatectomy, and 2 patients had external beam radiotherapy with brachytherapy. Most of the patients had ICIP3 disease. Half of the patients had positive margins on their initial surgery and half had negative margins. Most of the patients, as you'd expect, had T3 disease. The median PSA post-operatively was fairly good at 0.2. 14 of the 22 patients had radiotherapy after the initial radical prostatectomy. So all of the patients had a PSMA scan pre-salvage lymph node dissection. Median age at salvage lymph node dissection was 67. The median PSA was fairly high, I thought, pre-salvage lymph node dissection at 4.3. The median PSA post was 0.9. The median number of nodes harvested was 2. And the median current PSA at this point in time is 1.7, at a median follow-up of 18.7 months. So 15 patients had hormones at the time of their salvage lymph node dissection. Most patients had a targeted dissection rather than a full dissection, and most patients have ended up on hormonal therapy at the moment. There were 3 complications. There was an iliac artery injury resulting in claudication, which was repaired at the time. 1 patient had hydronephrosis with a nephrostomy, and 1 patient had a bladder injury requiring a catheter for 2 weeks. So in terms of future trials, the postponed trial is going to look at, as a randomized trial, looking at the templates for salvage lymph node dissection, comparing a unilateral versus a bilateral dissection in the setting of biochemical recurrence. A trial in Vienna is looking at salvage lymph node dissection as further looking at salvage lymph node dissection. The STORM trial is looking at salvage lymph node dissection plus or minus whole pelvic radiotherapy. And the RAVENS trial is looking at SAVOR with radium. So moving on from metastatic-directed therapy, I'd like to finish the presentation with reviewing systemic therapies for oligometastatic prostate cancer. So the first one to talk about is docetaxel. So docetaxel was reviewed in the CHARTED study and the STAMPEDE, as well as the GETIC study. So just to review, docetaxel is a taxane. It binds to tubulin and stabilizes microtubules to inhibit tumor proliferation. So the first study to talk about is the CHARTED study by Sweeney in the New England Journal in 2015. They had 790 patients with metastatic castrate-sensitive prostate cancer and randomized them to docetaxel and ADT versus ADT and placebo, and a median follow-up of 28.9 months. And focusing in on the oligo group, they had 35% of patients in the low volume group in each arm. Now, as I was saying, they define high volume as 4 or more metastases with 1 outside of the extraaxial skeleton or visceral metastases. So this definition of between low volume and high volume doesn't quite fit with our definition of oligometastatic disease. However, it's the best we have, best in terms of looking at literature for this. The primary endpoint was overall survival, and they found no statistically significant difference in CHARTED between the 2 groups in the low volume metastatic burden group. That 6.2% of patients had febrile neutropenia and 0.5% had sensory motor neuropathy. However, in a post-hoc analysis of the STAMPEDE data, there are suggestions that there may be a benefit of docetaxel. However, in my mind, when putting all of this together, given the comorbidities or given the adverse effects of docetaxel and the presence of other alternative options, I don't think those chemotherapy should be high up on our list for managing oligometastatic disease. Looking at abiraterone, so abiraterone is an irreversible inhibitor of cytochrome P17. The most relevant data for oligometastatic disease comes out of a post-hoc analysis for STAMPEDE. There was a latitude study, as you're all aware, looking at abiraterone. However, their inclusion criteria was the patients had to have high-risk disease, and including patients with Gleason 8 disease or 3 or 4 or more metastases. So their inclusion criteria excluded a lot of these patients. So in this post-hoc analysis, they had 402 patients classified as low volume using the same definition as charted. They looked at abiraterone and prednisone plus ADT versus ADT plus placebo, a median follow-up of 29 months. They found a statistically significant improvement in overall survival as well as failure-free survival. So certainly abiraterone could be considered in these patients early on. The ARCHES study looked at enzalutamide. So enzalutamide is a non-steroidal anti-androgen. This phase 3 study by Armstrong et al., published in the Journal of Clinical Oncology last year, had 1,150 patients, randomizing patients who had metastatic castrate-sensitive disease plus or minus previous local therapy versus ADT alone. They had a follow-up of 14 months with sequential imaging every 12 weeks. They had 37% in the low volume group, once again the same definition as before. Their endpoint was radiographic progression-free survival, and they found that in those patients with low volume, they had a statistically significant improvement in radiographic progression-free survival at their follow-up. So enzalutamide is certainly another option for these patients. Finally, apalutamide was looked at by the Titan study. Apalutamide is another non-steroidal anti-androgen. It was reviewed in a phase 3 trial by Chai et al. In the New England Journal of Medicine last year. They had 1,000 patients with metastatic castrate-sensitive disease, comparing them with apalutamide or placebo plus ADT. They had a median follow-up of 22.7 months. They had 37% in the low-volume groups, and they looked at both radiographic progression-free as well as overall survival. And they found that apalutamide had a statistically significant improvement in radiographic progression-free, however, not in overall survival in those with low volume. But this may be just a matter of follow-up before they identify a difference in overall survival as well. I'll just skip over that due to time. However, in conclusion, I'd like to suggest that we consider metastatic-directed therapy in selected patients. We need further randomized trials with long-term data. However, the take-home message of this talk, I think, would be that we need better prognostication and selection tools in order to tailor treatment options for particular patients based on where they are on that continuum. And we need to have, those molecular markers, imaging markers, in order to guide us as to how we manage those patients. And ultimately, the question really becomes: do we change the natural history of oligometastatic prostate cancer with all of our interventions? I'd like to thank Dr. Glee for his guidance as well in this talk.